Good morning, everyone. Thank you for coming for day 2 of our session. I will be reviewing Section A, Administrative Information, with a few updates, including expanding on the program interruption item removal and the Social Security number removal initiative. On this slide, as in all of the other presentations, we have for you a list of acronyms that will be used in the presentation for your reference. And on this slide as well. So in this presentation today, we will define Section A and explain its intent. I'll share with you the new items and the changes for the LTCH CARE Data Set version 4.0, and we'll review the coding instructions for these items. In addition, at the end of the presentation, you should be able to identify items being removed from Section A and explain how the Social Security number removal initiative will impact our data collection on the LTCH CARE Data Set tool. Overall, the intent of Section A is to capture key information that uniquely identifies the patient as well as our LTCHs in which the patient receives their services, and the reason for the assessment. So jumping right into the first section, we'll begin our detailed review of the section with the changes for the LTCH CARE Data Set from version 3.0 to version 4.0. First, the program interruption items in A2500, and this was the yes-no question which indicated if a patient had program interruptions, as well as A2510, which is the number of program interruptions during the stay, and A2525, which is the start and end dates of the interruptions, up to 5, have been removed from the LTCH CARE Data Set version 4.0, as data collection and reporting on these details was burdensome to some providers. I'm sure many of you in the room felt that way. I know I did. And I know that you are all going to appreciate it as much as I do. In Section A0600, no changes have been made to the item set. However, changes to policy dictate changes in the coding instruction for this item, and we'll review the policy change in the subsequent slides. So now we're going to walk through each of the data elements in Section A and provide coding guidance, including the changes that we spoke about for Section A0600. Remembering that the intent of Section A is to gather identifying information about the patient and the facility, the first element in Section A, which is A0050, asks us to code what type of record we are entering. A0050 asks us to indicate if the assessment is a new assessment, a modification to an existing record that we've previously submitted, or an inactivation of an existing assessment record. There are no changes to Section A0050. We would use A0050 modifying an existing record if the LTCH CARE Data Set assessment was already submitted to the KEYS ASAP system, and we are now updating inaccurate information. For these modification requests, we cannot modify the ARD, the admission date, the reason for assessment, the discharge date, or any of the patient identifiers in Section A. If we are requesting an inactivation of a record, we would need to have all of the information from the original submission to submit as part of the inactivation request. All of the values must match the original submission. So for example, if A0600A, Social Security number, was blank on our original submission, we would also leave it blank on the inactivation record. Inactivation requests are used when the event did not occur. So for example, if a planned discharge assessment was submitted but the patient ultimately was not discharged, this would be a case where we would use the inactivation request. Section A0100, Facility Provider Numbers, is also an unchanged section. Here we are providing the identifying information for the LTCH. The LTCH needs the NPO and the CCN numbers, as well as the state Medicare, Medicaid provider number when it's known. The next section is A0200, type of provider. And this section is quite simple as there's only one item for us to select, and that's long-term care hospital. There are no changes to this section. LTAC, or LTCH, and long-term acute care hospital are the same type of hospital. We often hear these terms and these acronyms interchanged. Medicare uses long-term care hospitals and abbreviates it as LTACs, or LTCH, and we are categorized by our certification as acute care hospitals with patients requiring extended hospital-level care following a short-stay acute hospitalization. All LTACs CCN numbers range from 2,000 to 2,299. The assessment reference date, or ARD, is captured in A0210. This is the end of the assessment period and can be no greater than the third calendar day of the patient's stay. Any assessments outside of the ARD are not included in the LTCH CARE Data Set. For example, if you find a patient weight in the record that's been completed on the fourth calendar day and you really want to put it in, you can't because it's outside of the ARD. So for this section, it would not be allowable in section K0200B to put that in as the patient's weight for assessment. The ARD is the discharge date for planned and unplanned discharge assessments, and in the case of an expiration in an expired assessment, the ARD date is the date of death. Again, there are no changes to A0210. This is how it appears on the CARE Data Set tool. All boxes in the date need to be completed. So if you have a month or a day with a single digit, you need to add a 0 preceding the date for the month or the day. The admission date is documented in A0220. The date is used to match records in the KEYS ASAP system. When entering information, you need to use the most recent date of admission to the LTAC. Many times we have multiple admissions to the LTAC, but you must use the most recent. There are no changes in section A0220. Section A0250 is the reason for assessment, why you are completing the LTAC CARE Data Set tool. There are no changes to section A0250. Here you have 4 options to choose from: admission, planned discharge, unplanned discharge, and expired. Admission is completed when the patient is admitted, of course. Expired is completed for patients who have passed on. For unplanned discharges, here are a few coding tips. An unplanned discharge is a transfer of the patient to be admitted to another hospital facility that results in the patient's absence from the LTAC for longer than 3 calendar days, including the date of transfer, or the patient's discharge date from the LTAC. Or an unplanned discharge can be a transfer of a patient to an emergency department or another hospital to either stabilize a condition or determine if acute care admission is required based on emergency department evaluation, which results in the patient's absence from the LTAC CARE Data Set or LTAC setting for longer than 3 days. When a patient unexpectedly decides to go home or to another facility, have an AMA, this would also be an unplanned discharge assessment. In these cases, you have assessment information that may not be available. If you're unable to answer a particular item on the LTAC CARE Data Set due to the inability to assess prior to the unplanned discharge, you would code the item with the default response of a dash. CMS expects dash use for some quality measures, but it should be a rare occurrence. The use of dashes for items necessary to calculate our quality measures may result in a 2% payment reduction to the LTAC's annual payment update. So you really do want to use the dash sparingly, but when it's appropriate. If the patient is transferred out and returns on day 2, this would be a program interruption, and therefore there's no assessment required for the LTAC CARE Data Set. And then a planned discharge is our fourth option. It's important to point out that a planned discharge with a change in discharge date should be coded as a planned discharge. It's not considered an unplanned discharge. So for example, if a patient is originally scheduled for discharge on December 8th and it's delayed until December 9th, you would still use the planned discharge assessment and use the actual date of discharge. It's still a planned event in this case. There are no changes to section A0270, which is where we document our patient's discharge date. Moving on to section A0500, legal name of the patient, is another section that's used for matching data in the KEYS ASAP system, and it's also unchanged. A few important coding tips for this section: you must use the patient's legal name, no nicknames or shortened or abbreviated names. You can leave A0500B blank if the patient has no middle initial. Use the initial of the first middle name if the patient has more than one middle name. And you can use various sources to get the middle name when all of your validated methods, such as license or government-issued documents, are not available. You certainly can reference the patient's family, guardian, or caregiver to get this information. So section A0600, Social Security and Medicare numbers, is one of the items on the CARE Data Set tool that has not changed from a coding perspective. However, there is new guidance that will affect how we code this section. You can see that the fields in this section for completion remain straightforward and request the Social Security number and the Medicare number. If the patient does not have a Social Security number, the item may be left blank. The health insurance claim number may differ from the patient's Social Security number in some cases. For example, if a patient is utilizing a spouse's Medicare eligibility, so that's acceptable for those two numbers to sometimes not match. The changes to the coding instructions for section A0600 are listed here. These changes were made to deter identity theft. I'm sure most of you are aware that CMS is replacing the Social Security-based health insurance claim number with a new identifier, Medicare beneficiary identifier. The health insurance claim number may be different from the Social Security number, as I mentioned, but we need to account for some transition here. This transition impacts how we will submit the data in A0600. Here's a few very important dates for us to know in the upcoming years. If you have a patient assessment that is being completed prior to April 1st of 2018, you will continue to enter the Social Security number-based health insurance claim number in section A0600. If you have a patient assessment that is being completed between April 1st, 2018 and December 31st of 2019, you will enter the patient's Social Security-based health insurance claim number or the patient's Medicare beneficiary identifier if available at that point. If you are completing a patient assessment after December 31st of 2019, you will exclusively use the Medicare beneficiary identifier. There should be no use of the Social Security-based number, health insurance claim number, beyond 12/31/2019. Section A0700 is unchanged. Here we are entering any Medicaid numbers. It's important to know that if you're notified later that a patient has a Medicaid number that maybe was just issued, please just include it on your next assessment for that patient. Section A0800, gender, is unchanged at this time and is another section that's used for matching identities within the KEYS ASAP system. You need to select either male or female for this section. Section A0900, birth date, is another matching element for the KEYS ASAP system. There are no changes to this section. And when completing the birth date, you do need to make sure that all of the fields are completed, so you'll use zeros to fill in blank spaces in this section as well. If only the birth year is known, then the a year can be entered in the box for A0900 and leave the other information blank. Likewise, if the information is only known for the patient's birth month or birth year, you can certainly leave the day boxes blank. If the birth year and the birth month are known, but not the day of the month, you can enter the year in the year boxes and enter the month in the month box and leave the day blank. And there's an example there of how that would look on your assessment record. Section A1000 has no changes. This section represents race ethnicity codes. The race ethnicity codes use the common uniform language approved by the Office of Management and Budget to report racial and ethnic categories. The categories in this classification are social, political constructs and should not be interpreted as being scientific or anthropologic in any nature. When completing this assessment for race ethnicity, you should ask the patient to select the category or categories that most closely correspond with his or her race or ethnicity from the list of items in A1000. Individuals may be more comfortable if this question is introduced by saying something to the effect of, "We want to make sure that all of our patients get the best possible care regardless of their race or ethnic background. We would like you to tell us your ethnic and racial background so that we can review the treatment that all patients receive and make sure that everyone gets the highest quality of care." That's really the intent of this section. If the patient is unable to respond, asking a family member, significant other, guardian, or legally authorized representative is acceptable. You can provide category definitions to the patient, family, significant other, guardian, or legally authorized representative if they request them to help them answer the question. Offer the option of selecting one or more designations for racial and ethnicity codes, as you can select all that apply. Observer identification or medical record documentation to code this item should be used only if the patient or another source in the family caregiver or authorized representative is unavailable to answer the question. A1100 language. Language barriers can interfere with accurate assessment of patient condition, treatment planning, and healthcare delivery. Section A1100 records the preferred language of our patients and identifies patients who need interpreter services to communicate with healthcare staff, participate in their care decisions, or participate in and understand the consent process. In order to ascertain if an individual wants or needs an interpreter, hospital staff should be consulting first the patient if they're able to communicate with you, but also consulting the family, guardian, or authorized representative. If none of these individuals are available, the record should be referenced for evidence of the need of or previous use of an interpreter. This section has not changed. And again, here's how this section A1100 appears on our LTCH CARE Data Set. A1200 marital status is an unchanged section as well. Here we are identifying formal relationships of a patient as it is important for discharge planning. Similar to other sections we've discussed, a family member, guardian, significant other, or authorized representative can be consulted, and in their absence, and if the patient is unable to communicate, the medical record can be reviewed. Section A1400 contains payer information, and this is another section where we would select all that apply. Knowing the patient's previous setting prior to admission helps to inform the delivery of services and may also help with discharge planning as well. Section A1802, admitted from, asks the LTCH to document the patient's setting immediately preceding their current admission. A two-digit corresponding code will be entered. There are also no changes for Section A1802. Oops. I skipped over my final slide, so I'll just let you know that A2110 2.10 discharge location should be documented on the planned discharge and unplanned discharge assessments, and that section is also unchanged. So here we have our first knowledge check. This is a polling question, so you're going to want to make sure that somebody is designated to push the button on your polling device. We want to see what we've learned about Section A or refreshed our memory on. So our first question is, after which date are you to enter only the patient's Medicare beneficiary identifier and no longer the Social Security-based health insurance claim number? I'll give you a few minutes to go ahead and punch that number in, that selection in. Okay. Okay, so it looks like everybody is just about finished. And our responses indicate 96% of us have identified December 31st of 2019, and that is the correct date. So this is one of the dates that we're going to want to make sure we communicate to our teams. Okay, and knowledge check number 2. Although Mrs. G's discharge date was rescheduled, it remains a planned discharge and is not considered an unplanned discharge. Is this true or false? Okay, it looks like most of you have entered your response. So 96% of us chose true, and true is in fact the correct answer. Remember, even though the date may have been moved, it is still considered to be a planned discharge. We were planning for that person to leave the LTAC. Okay, here's another one, knowledge check number 3. Which Section A item has not changed in LTCH CARE Data Set version 4.0? And here we can select from our discharge location, Social Security and Medicare numbers, program interruptions, or program interruption dates. Okay, looks like everyone has entered their response. So 100% of us chose discharge location, and that is the correct answer. If you remember, we reviewed Social Security numbers and Medicare numbers. Program interruptions, are, of course, are changing. So let's talk a little bit about the program interruption section. So moving on to Section A2500, A2510, and A2525, we can all celebrate that these have been removed. Removal of these elements from LTCH CARE Data Set version 4.0 will be effective July 1st. All of the definitions and the guidelines associated with the LTCH QRP and program interruptions still apply, however. So for example, when you have a patient who goes out of the facility, returns after 2 days, but has a fall in the other setting that they were in for those 2 days, that program interruption definition is still applicable, and we would code that as a fall as part of their current stay. And we'll talk a little bit more about that later on. So the definition for program interruptions of being out of the facility for less than 3 calendar days is still applicable while we're coding other sections. And we'll review some examples of that when we go through the other sections later on today. However, we don't have to count the individual program interruptions anymore. So again, just expanding on the definition a bit, the program interruption refers to an interruption in a patient's care given by an LTAC because of a transfer of the patient to another hospital or facility. The interruption must not exceed 3 calendar days, as I mentioned, and day 1 begins on the day of transfer, regardless of the hour of transfer. As mentioned, when a patient has a program interruption, a discharge assessment is not required for submission. So it is important that we know how many days the patient is outside of the facility. If it's fewer than 3 days, we would not have to do a discharge and then a subsequent admission assessment when the patient is returning. If they are out longer than 3 days, that's when we would have to do a discharge assessment as well as an admission assessment when the patient is readmitted. So you can see how the definition is still applicable, although the elements have been removed from the CARE Data Set tool. So let's do a quick knowledge check here. Here's our knowledge check for this program interruption changes. The definitions and guidelines for program interruptions no longer apply since the program interruption items have been removed. Is this true or false? Okay, and it looks like everyone has submitted their responses. 96% of us chose false, and that is the correct answer. We want to keep that definition of program interruptions in mind, as I mentioned, because we will be utilizing it for coding other sections. However, we do not have to enter the information in A2500, A2510, or A2525. So in summary, the majority of Section A is unchanged. Of course, the program interruption section that we just reviewed has been removed to reduce the burden on all of us, which we appreciate very much. The Social Security number removal initiative also has required us to have some changes to our coding instructions, but the section itself has not changed. So now that we have the overview of Section A, you'll want to create an action plan to share this information within your facility. So it's important that you go back and you make sure that everyone involved in completion of the medical record as well as the LTCH CARE Data Set assessments is aware of these changes. So everyone should be communicating and have an action plan to communicate the timeframes for transition from the health insurance claim number, which is Social Security based, to the Medicare beneficiary identifier. You'll want to review the program interruption definitions and changes so that we're refreshing everyone's mind on program interruptions and how they're applicable in other areas of the CARE Data Set tool, but also that we no longer need to count the individual program interruptions when completing our assessment. This concludes our Section A overview of administrative information and updates. I'm going to turn the presentation over to Carol Schwartz from RTI International, who will review Section G, functional abilities and goals with you.